So for this part of the slide set, I'm going to vary a little bit from what I posted as the voiceover PowerPoint that is already developed from last year, because you will be doing a different homework assignment and not doing the tweet exercise. The next few slides are just quick drive-bys on a couple of conditions that were in your condition list for this lesson. I'm going to poke into the YouTube here and play it for you because I think it's a perfect example of what tinnitus or tinnitus, however you say it, sounds. And you can get more information from the article posted in the readings. That's kind of a fairly detailed review about tinnitus. So one of the things I'll challenge you to think about here is what kind of history questions you would want to ask the patient as you tried to sort out what the cause of the tinnitus was. Again, this is kind of more in the chronic problem realm, but occasionally people will have short-term tinnitus associated with some of the ear problems as described in your text. Again, kind of jumping through quickly in a drive-by fashion, in this video that was posted in your readings, I think it gives an excellent overview of the TMJ and really how it works and what is causing the various symptoms that patients report. Again, also can be kind of a chronic problem, but you can acutely get someone complaining about a new onset of TMJ. And one of the differentials I think we kind of touched upon briefly in class when we talked about chest pain is radiation. And radiation to the jaw is one of the things we worry about when we hear someone talking about having a left jaw pain. We might think that it's cardiac in nature, as that's one of the referral locations for pain from cardiac ischemic pain.
Mandibular joint, commonly referred to as TMJ, is a paired joint where the mandible, lower jaw, meets the temporal bone, base of the skull, just forward of the ears. Since it is a paired joint, the right and left sides must function together in harmony. This is a very complex joint. As a matter of fact, the temporomandibular joint is the most complex joint in the body. It is the only joint in the human body to have a rigid endpoint of closure. That is where the teeth make contact to limit jaw movement. It is also a compound joint, a joint involving at least 3 bones in the body: the mandible, the temporal bone, and the articular disc. The TMJ is not well understood and tends to be an orphan that belongs to no particular profession. Only about 24% of MDs and only about 10% of dentists have received any postdoctoral training in the diagnosis and treatment of TMJ disorders. You can imagine the strain that we place on this joint as we breathe, talk, eat, and swallow 2,000 times per day. It is no wonder that 34% of the population reports some level of disorder in the TMJ. The normal movement of this joint is both a rotation and a sliding motion. As we begin to open our mouths, the rotation aspect of movement begins, and as we continue to open the mouth, the lower jaw actually begins to slide downward and forward. The basic components of this joint consist of bone, tissue, muscle, ligaments, tendons, and a disc which acts like a small pillow or cushion protecting the joint from wear, sort of like a shock absorber. TMD, or temporomandibular joint disorder, is characterized by signs and symptoms including pain in the area of the TMJ or the surrounding muscles, which often limits the mandibular range of motion. TMD is typically caused by various types of trauma. When the disc remains in its proper position during normal opening and closing of the jaw, no clicking or popping should occur. If the joint makes noise when opening and closing, it is due to friction within the joint. There are several adverse conditions that occur in TMD situations. Open lock is when the condyle and disc move too far forward and get caught over the anterior slope of the eminence of the temporal bone. This is an open lock and will cause the patient to have difficulty closing his mouth. Disc displacement with reduction is caused by trauma that has damaged or stretched the ligaments, causing the disc to be out of position too far forward in relation to the head of the condyle. As the mouth begins to open, the disc is in front of the condyle. As the condyle slides downward and forward, the condyle pops back into position on top of the disc. This causes a popping or clicking sound. When closing the mouth, the disc remains in its proper position, and then just before the condyle returns to its position of origin, the condyle slips off the disc and another popping sound occurs. This second sound may be softer and not as noticeable. Disc displacement without reduction is when the posterior ligaments have been severely stretched or torn. These are the ligaments that hold the disc on the head of the condyle. If this occurs, the disc remains in front of the condyle throughout the entire opening and closing process. Most TMD patients worsen with time. Slight clicking advances to more frequent clicking and eventually to jaw locking as the posterior ligaments continue to stretch, allowing the disc to move further and further out of position. When the disc is slipped too far forward or inward, the jaw will lock shut, often referred to as a closed lock. An acute closed lock, occurring usually due to trauma, is a situation in which there is an audible noise or pop as the disc slips out of place and the person cannot open their mouth. Chronic closed lock is a problem that persists for more than 6 months. The disc is never positioned between the bones in the opening and closing cycle. During this time, the disc will degenerate and lose its shape. The patient may begin to open wider and wider as the disc is slowly destroyed. Pain and arthritis will set in due to bone-on-bone rubbing. Depending on the severity of the problem, there are several treatment options available to treat TMD. Splint therapy consists of the placement of removable or fixed dental appliances which protect or keep in place the injured body part. The purpose of this type of therapy is to reduce the inflammation and pain. This type of therapy will not restore all of the damaged or degenerated components. Orthotic therapy is similar to splint therapy. However, an orthotic is used to support, align, prevent, or correct deformities, or improve the function of movable parts of the body. The goal of orthotic therapy is to provide the best condyle-fossa relationship possible, to decompress the joint, which reduces inflammation, and to restore correct muscle length bilaterally. Surgery is only recommended in about 2% of TMD cases. As with all medical treatment, diagnosis is key. Your physician or dentist may refer you to a doctor, either MD or dentist, who has received extra training in the diagnosis and treatment of TMD. You will undergo testing to determine the cause and extent of dysfunction and be given treatment options. Comprehensive treatment may include referral to other professionals such as chiropractors, naturopaths, physical therapists, massage therapists, or podiatrists to provide you with whole body care to address your condition.
Temporal or giant cell arteritis is another condition on our condition list for this week. We're probably going to visit it later on when we talk about differentials for headache because it usually presents as headache. I'm just going to point you to the guideline that was listed in your reading materials just to get you started on thinking about giant cell arteritis. So again, because the original set of slides referred to a homework activity calling diagnostic tweets, you can ignore that. You will not be doing that assignment. Instead, you will be doing a fun puzzle that I will be posting on Blackboard for you to work together on if you want to, and submit just as a review for this lesson. Thank you, and we will see you next week.